Next, I'd like to welcome Dr. Kanthi Vemuri for an update on newer antifungals. Dr. Kanthi is currently working as a transplant ID physician at the Prince Charles Hospital, and she has completed an immunocompromised host infections fellowship from the University of North Carolina back in 2023. She's actively involved as a committee member for the Transplant Infectious Diseases Special Interest Group with the Transplant Society of Australia and New Zealand. Kanthi is passionate about promoting the recognised importance of transplant infectious diseases expertise in patient outcomes and is keen to work towards strongly collaborating with transplant physicians and integrating infection prevention and management in immunocompromised patients. All join me in welcoming Kanthi.
Good morning, everybody, and thank you for being here and giving me this opportunity to talk about an exciting topic, update on new antifungals, which I think has been exciting for the last 5 years. And I'm pretty sure most of you in the room have already attended a talk on this. So I'm very mindful that there has been a very slow progress, but some progress in this space. And given there's not very much in terms of data to report, I have tailored my talk to be able to understand why this is so challenging in terms of developing the new antifungals, and also learning the importance that these agents are going to or fill the gaps in our day-to-day clinical practice if and when they will be available to us. So I don't have any financial disclosures. I don't work with any of these companies, and a few data and images are subjected to copyright, which I'm going to share with you today. So they're meant to be only for educational purposes. So we all know that fungal infection burden is increasing, as shown in the Global Action for Fungal Infection recent report, where both the incidence and mortality has been rising with time, and increase in immune-compromised population has further increased these numbers. Just bringing an Australian perspective and health economics into the picture, even within Australia, we've spent almost $600 million in treating invasive fungal infection patients, and each IFI diagnosis costs around $30,000, which triples if they go into ICU. What do we have currently? Are a group of so-called effective antifungals, but again, the challenges that we have with the current arsenal is that they all need a nuanced understanding of their spectrum, very poor penetration into the sequestered sites, and of course, we all know about the side effects and the drug interaction profiles needing close monitoring. Global warming has increased the ability of the fungi to tolerate in higher temperatures. Their thermotolerance is increasing, which is making non-pathogenic fungi even more able to cause infections in the warm human body. And this is also concerning because the antifungal resistance, which is expected to happen, but is exacerbated by the overuse of antifungals, both in agricultural field as well as within the clinical field. What we actually are looking for in terms of newer antifungals are to have a more broader spectrum, less side effects, poor minimal drug-drug interactions, and also more oral formulations to be able to discharge patients home. When I started this talk and was given the topic, I really felt like I myself need to understand what is the hurdle in developing antifungals and why is it taking so long. So going back into the biology of these molecules, what it feels is like both the humans and fungi share the same eukaryotic machinery. So when we're trying to develop an antifungal molecule, we want something which is very substantially selective, does not interact or has minimal interaction with host proteins, that is the human beings. We are already the current arsenal we have are more fungi static. So what we're looking for, not in the same space, we want more rapid fungicidal activity, and also broaden the spectrum for more resistant molds because of the increasing new fungal pathogens that are emerging. And of course, resistance, if they don't develop resistance, that's amazing. But then also the safety for the patients in terms of drug-drug interactions and side effects. So as you can see, we need a lot in one molecule to start with. And then even if all this is passed, and then you come to the approved drug approvals, in the last 10 years, we had four antifungals approved, and still the invasive fungal infection space has not got any advantage of this, because two of those are more for vulvovaginal candidiasis. And what we have for the invasive fungal infection space is isavuconazole, which has already been for a while and we've started using it. And the only new one has been the rezafungin, which we will talk as we go. So what happens? Like, you find a molecule, and then it's important to then understand whether this molecule can actually make it to the pharmaceutical phase, which is like, it has to be stable, and then it needs a lot of biochemistry and pharmaceutical companies to take interest in this drug to be able to proceed, which means more money. And then even if it proceeds to a stage where we have to do a study, then the issues are fungal infections are serious infections, which we're looking for, which means like they have to run longer. Recruitment is harder. We need at least decent amount of patients, which means like we have to incorporate multiple sites to be able to pool those numbers. And then comes the cost of running the study in multiple sites. And then what is the incentive for the pharmaceutical companies to do that? Very minimal, because it's a pay-per-use model. So once this drug develops, it only depends on the usage, and that is a very minimal amount that they get. So there is not much of a financial incentive. So I think the economic model is broken. Even though FDA and the European medical approvals are fast-tracking antifungals, like they are accepting cohort studies, not looking for randomized studies, I think there's much more challenges, and that's what we're seeing in not having these medications hit the market as soon as we want them to. This is reflected in the latest report by WHO, where you can see that there's so many in the preclinical state, but hardly 3 drugs in the phase 3, and again, due to the same issues. And if we have 3 drugs in the phase 3, which means like they might hit the market in the next decade. Another more drugs in different phases that they have published this year. So there's some light that more and more drugs are being repurposed. They are looking for label extensions and novel agents. But when are they going to be actually available for us is always a guessing work. So this is what we have now, and these are what we're going to talk, which looks very disheartening with so many red crosses, but most of them are in phase 2 and phase 3 trials. What's available, the 2 green ticks is a rezafungin, which has hit the markets in 2023, and it's in USA, not for us yet. And then there are other drugs which we will go in detail. Just a quick recap of the mechanisms of actions for the antifungals. As you can see, the known mechanisms of action on the right side of the screen. Azoles, which are in the ergosterol synthesis pathway. We have 2 drugs, the oteseconazole and the opelconazole. And then in the polyenes, interestingly, this is something which would be really wonderful if we can get them, is the N-cochleated amphotericin B, which is the same liposomal amphotericin B, but is wrapped in a lipid formulation, and it's an oral formulation, which if we can, which limits the toxicity. Very early stages of development. And then we have the beta-D-glucan synthesis inhibitors, which is the echinocandin family mechanism of action, and that's rezafungin and ibrexafunga. Novel mechanism of actions are ones which we don't have yet and are hitting the market. The first one in that is the manogepix, which is a GWT1 inhibitor, which is important enzyme to anchor the manoproteins on the fungal cell wall, which then helps in the cell wall integrity. So it's another antifungal which works on the cell wall of the fungi. And then there's some mitochondrial respiratory chain inhibitors, which is very early in development, which we will not be talking today. And then olorofim, which I'm sure some of us have had the experience of already using it, is a new pyrimidine synthesis inhibitor, which acts via the dihydroorotate dehydrogenase inhibitor. Starting with rezafungin, which is actually available, was approved in March 2023. What is it giving us new in the echinocandin class is that it's a long-acting echinocandin where we only need it. It can be administered once weekly, so can help with the patients that need to be discharged for longer treatment with echinocandins, and helps us to not need PIC because it's once weekly. The mechanism of action is the same. The spectrum is slightly broader with Aspergillus, fumigatus flavus, and pneumocystis, but the same disadvantage of echinocandins, which is sometimes higher MICs for Candida parapsilosis, is there with the rezafungin as well. Minimal drug interactions. The STRIVE and RESTORE are the trials which made it get its approval. And what the RESTORE trial has showed that it is non-inferior to caspofungin in candidemia and non-invasive candidiasis. A new trial which is going on in phase 3 is the RESPECT trial, which is using this medication for prophylaxis within the hematopoietic stem cell transplant patients, which would be very interesting to see the results. What are the gaps with rezafungin? It has not been studied in patients with deep-seated metastatic infection, which I feel is the gap which we still have. But in saying that, the difference is that the echinocandins that we have at the moment, caspofungin and igilofungin, were also approved in a similar way. They were not studied in these situations, but then phase 4 studies have shown that it can be effective. So maybe we can extend that to the rezafungin as well. It's not active against Cryptococcus and non-Aspergillus molds. An important point is that in the RESTORE study, there were less than 7% of patients with absolute neutrophil counts less than 500. So again, questionable within our febrile neutropenic patients. Because the RESTORE trial was not tailored for ICU population, what they did is a post hoc analysis with the pooled data, which still showed the same outcomes, that it is inferior to caspofungin, and a clinical response was more quicker with rezafungin. Moving on to the azole, the oteseconazole is the azole which was approved for vulvovaginal candidiasis. What we have here is that it has been shown non-inferior to fluconazole for acute vulvovaginal candidiasis. But then when compared with the placebo, it was superior in preventing recurrent vulvovaginal candidiasis. The one aspect that I wanted to highlight was most of the patients in these trials had Candida albicans. So the usefulness of oteseconazole in non-Candida albicans candidiasis is hard to extrapolate, but preclinical studies have showed that it works in vitro with even azole-resistant Candida albicans and Candida glabrata. This is a summary of the same thing. So future for this study, they are looking at its usefulness in onychomycosis, which we know is a very difficult to treat infection. So it would be interesting to have another agent in this space. And then in terms of gaps, it cannot be used in reproductive age patients and lactating women. And as I said, small number of non-Candida albicans patients in the studies. Moving on to ibrexafungerp, a very busy slide. I apologize, but mainly what I'm trying to get here is like this is a synthetic beta-D-glucan enzyme inhibitor. It is an oral medication, so we now have an oral step-down option. And it has been already approved for its, again, in the vulvovaginal candidiasis phase. So what they're now doing is to like extend it to see whether there is a role within the invasive candidemia and invasive molds. The Fury phase 3 trial has concluded the study, but we are waiting for their results. They did publish an interim analysis last year, which has showed almost 82% of patients achieving clinically positive outcomes and 94% having survived the 30 days post-therapy in invasive candidiasis and candidemia. They're also including recruiting patients for pulmonary aspergillosis, so it would be good to see the results. They also tried to, because it's an oral agent, step-down agent post-echinocandin therapy called the MARIO study. Unfortunately, that has been suspended because of some cross-contamination at the manufacture site, which is again another issue with these studies and trials running and trying to get the approvals. So fewer drug-drug interactions. I think the advantage that ibrexafungerp has is its activity against Candida auris. So it's a drug that everybody's looking forward to. So I'm hoping that the Fury trial will push it and then it'll be available. But again, the same gap exists, which is fetal harm was seen in animal studies. So it'll be interesting to see what the Fury trial is going to talk about this. And they're also investigating this in the management as combination therapy with voriconazole in invasive aspergillosis. Moving on to olorofim, which is expected to hit the markets in 2026 and is a first-in-class antifungal drug. Belongs to the orotamide family, inhibits the dihydroorotate dehydrogenase. I put that slide there for its spectrum because just to highlight that there's the big gap here is that it is not a yeast antifungal, so there is no cover for antifungals here, and also unfortunately not for the mucorales as well, which is also something that we're all looking forward to. So it's a good anti-mold antifungal, but the gaps is that it does not cover mucorales. The phase 2 trial was positive, like they had 44% successful response rate, and they felt this is good because the patients that they treated were invasive fungal infections with limited or no treatment options. So they went with this data to FDA, but FDA has not given them approval, saying that they need further studies to compare with the standard of care. So OASIS phase 3 clinical trial is on its way, where they are comparing it with liposomal amphotericin B, and hopefully this data, if it is non-inferior or even slightly better, we would be seeing this being approved next year. As I said, the spectrum is the advantage for it. It is active against resistant molds like Lamentospora, Scedosporium, and azole-resistant aspergillus. The OASIS is underway. Peak pharmacokinetics profiling is so far that we have seen is good, except for deranged liver function is something which needs to be monitored. And also there is some concern that there could be some acquired resistance mutations with Aspergillus fumigatus. Moving on to another azole, which is an inhaled azole. As we all know, at the moment, we only have a nebulized amphotericin as our inhaled agent. So that space can get a new one here, which is intriazole. Again, broad spectrum of activity between Aspergillus, Candida, Cryptococcus. So the initial study, the phase 2 study, was more for safety and tolerability of this medication versus standard of care, which was nebulized amphotericin in lung transplant patients for the first 3 months, and most of them were in ICU in the initial stages, and it was very well tolerated. So now it's gone into its phase 3 study, which is used as a combination treatment for invasive pulmonary aspergillosis, which I think is a good way to have a more local inhalational delivery, especially in lung transplant patients when they're worried about the tracheal anastomosis infections. Fosmanogepix is the next one, which has is available both intravenously and has high oral bioavailability. Another advantage is it has significant central nervous system penetration. Again, in vitro efficacy against Candida, Aspergillus, and also echinocandin and triazole resistant strains. The important point to remember with fosmanogepix is that it is intrinsically resistant to Candida krusei. So if a center has epidemiology for Candida krusei infections, I think using this as empirically would be not advised. I guess this would be the gap that fosmanogepix has, and is showed 80% treatment success rate within the phase 2 trials. The phase 3 clinical trial is underway. I think one adverse effect which I felt was worth noting is that they've seen pleural effusion occur in 14% of the patients, which I feel in immune-compromised patients would probably trigger more investigations and more treatment. But I think the phase 3 trial results would give us more understanding of this. So this is the phase 3 trial, and I just put it out there just to show you the exclusion criteria. There's most of the patients, there's a lot of exclusion criteria, but then when I went back and looked for all the approved antifungals, it all looked similar. So I think this study is underway. 2 of centers from Melbourne are participating in it. So hopefully we'll you reach the numbers and have this out there. Side effects are mostly, as I said, similar to what we have now, excepting for the pleural effusion for fosmanogepix. One thing I noted was the oteseconazole, which was used in vulvovaginal candidiasis, has vulvovaginal pruritus, and UTIs as its side effect. So I just didn't understand how we can kind of differentiate between the patients as well as the symptoms from the disease or side effect from the antifungal. And then in terms of the PK/PD, as I said, the CNS penetration with Mano-GPICs and olorofim are really reassuring, which we need for our patients who have CNS fungal infections. It's the same slide showing organ penetration for all the things. And I, again, felt like the important thing to highlight here is we do not have any penetration for the kidney and the urinary tract still. So it's still stuck with the same challenges of treating any of the renal parenchymal fungal infections. So this is just a spectrum showing how these new agents are hitting the market. As you can see, there's a lot happening in the Candida space, and some good agents coming in the azole-resistant aspergillus space, and mucorales is still the gap where we have variable activity and something to look forward to. Then I just put this one to understand with the most common things that we deal in day-to-day life, where these agents can be useful. As you can see, most of the agents are useful for Aspergillus fumigatus, which is a major fungal infection that we see in immune-compromised patients. We have Cryptococcus getting a new agent with Mano-GPICs, and Candida auris is increasing. So we have some agents to look forward to for managing this resistant infection as well. So access in Australia, I think I put this slide, but I know Sean's going to talk about this, so I'm not going to dwell, but I just wanted to put there how I harass my pharmacists to keep asking for these things, even though they're not available, just to understand and close the loop that I tried, but we can't get it here. The prices, if you see, are pretty high. The turnaround time is also a lot, 7 to 14 days. So even trying to access these drugs is very hard, except for olorofim, who have a special access scheme, which I have been utilizing over the last 18 months. And there's no cost associated at this point because they are global. They're trying to get real world data, but how they approve the drug is very strict criteria. But once we get on the trial, they've been very good in communications and trying to get the drug in time as to how, as we finish the first lot, they're usually very good. So conclusions are that we still have some limitations, even with the newer antifungals hitting the market, but we have some step-down options. Gap for mucormycosis still persists, and so is for the UTIs and renal parenchymal infections. Also, PK/PD parameters for obesity, chronic renal or liver disease, and pregnant women still needs to be seen in phase 3 and phase 4 trials. Future may lie more in maybe immune modulation, which is having some space in treating these infections, and also highlights all the importance of the need for fungal surveillance and antifungal stewardship. Thank you.
Thanks so much, Kanthi. Mixture of blessings and conservative doom on the horizon on some of those issues.